The meeting open to the public. Okay, members, committee meeting will be recorded and broadcast throughout Parliament buildings and also online. So, apologies from Colin and Orlea. Anybody aware of any other apologies? No? So, Diane and Nuala are going to be joining us online. Can I just advise members in the public gallery that they're welcome to use mobile devices as long as they're in airplane mode and all devices are muted. The assembly Wi-Fi and password details are there in the gallery rules, and it's not permitted to take photographs or record any of the meeting. Chairperson's business. So can I thank Nick for meeting with the committee informally on Tuesday. It was a very good discussion covering a wide range of issues, but in particular, if members are content, I would suggest that we write to the department in relation to re-establishing the partnership forum and to encourage the department to engage with trade unions at the earliest possible stage in relation to any reconfiguration, and that also that the committee looks forward to engaging with Nick Ictu during the committee's scrutiny of forthcoming legislation. Everybody content with that? Okay, thank you. Also, just members, I was invited to attend the Southern Area Hospice 35 years celebration event yesterday in Portadown. It was very good. So, I from the committee, I want to publicly congratulate the hospice for the 35 years and thank them for the service that they have done and continue to do, and also just to alert members that they're no longer going to be known as the Southern Area Hospice. They've rebranded themselves as Evera, and so that's what they're going to be called moving forward, and they give very good reasons and rationale, A, for the name, and B, for why they have rebranded themselves, and they've got some very ambitious plans moving forward. So again, can I wish them well now as Evera moving forward, and encourage members maybe to visit their new website. Also then, just briefly to mention Caleb's cause. Obviously, people will have been in the chamber the other day when the Economy Minister made a lengthy and detailed statement in relation to aspects of provision for children and young adults with special educational needs. As far as the Department for the Economy will go, I know some of the campaigners are disappointed that it doesn't encapsulate all of what they're asking, and I think we're all going to be disappointed from that. But at the end of the speech, the statement, the Minister for the Economy said that she would be engaging with the Health Minister and the Education Minister to kind of close the circle on all of these other issues. So, I would suggest as a committee that we write to the Minister of Health, first and foremost, to ask what specifics the Health Department are doing to deal with this issue from their department, and also that they engage speedily with the Economy and Education Minister, and that all three of them come together and close the loop, so that the kind of campaigning from Alma and Caleb's cause comes to fruition in terms of the totality of what they're asking for. Linda?
I think that would be really, really good, and I think it'll at least give those that have been campaigning, in particular Alma and Denise and others, that heart that this hasn't just been dealt with in economy and we're going to forget about everybody else, because it doesn't actually deal with our kids. I also think maybe if we can ask the department if they can keep us updated on conversations going forward, and is there a potential for some kind of a plan from a child's birth. Not all children will be diagnosed at birth, but many will, and how they then work with education, and education works with economy right throughout that child's life. Is there a plan, or do they intend to put in place a plan? It does start with health in many cases, because that's where the diagnosis will very often happen, where a child has particularly profound learning disabilities. So I think that we just need to get a sense of what is the plan going forward. How are we going to make sure that these children, in every aspect, rather than what we're doing at the minute is trying to deal with everything in an itty bitty way, and it affects every single element of their lives. So I'm thinking if there was a plan around each child from
Yep.
birth.
Okay. Danny and then Diane.
Chair, I would agree absolutely with that. I think this is a multi-departmental issue, and I think it was positive to have the Minister for the Economy come out and give her statement and give her plan of what she can do in her department. I think it's now up to the other ministers to come forward with responsibilities that fall under their departments and to join that up together. You know, these children do deserve improved services, absolutely, and that has to go through economy, education, health and communities, I think, as well. So if we can get that joined up. I think the Children's Cooperation Act a couple of years ago had suggested that departments have to work together for the benefit of children. So I think it's something we should be doing, absolutely.
Yep. Diane.
Yes, thank you. I thought the statement from the Economy Minister was interesting and had many interesting aspects of it that she could control within her department, which is fair enough. But there was also a really big gap in terms of health. And it is fine, and I know that time is tight for the committee at this stage before recess. But would it be possible maybe for us to get health officials to come and do a presentation on exactly what they provide and how they would hope to link in with any better provision or even any legal requirement to have provision maybe in September, October?
Yeah, I don't see that seems reasonably sensible.
I'm glad you think so, Chair.
Okay, thank you. Just also another issue then, myself and Danny had an engagement with a delegation of midwives and the RCM who were up in Stormont yesterday. So it was very interesting. We maybe spent an hour with them, Danny, in the afternoon, taking questions and having a discussion. So there's a lot of generic issues, obviously pay, workforce issues, training, etc. That you would expect. But one thing I wasn't expecting that they raised in particular was the issue of home births, and in particular the fact that in some cases home births are being videoed and ending up on social media platforms, and some of the midwives then are being subject to extremely cruel commentary. So, I would expect that if you have a birth in a hospital or any other healthcare setting, that you're not allowed to be videoed and posted on social media, and midwives and other healthcare staff are protected. I just am not sure what the case is with regard to home birth, so I would be suggesting that on the back of me and Danny's engagement that we write to the department and just ask them what protections they have, what are the rules, what are the regulations, how can the department support staff should something be posted online to ensure that it's removed as quickly as possible with regard to this issue. Linda?
We might even want to make it more general, because there was an issue that was raised, I think it was this week, by healthcare professionals in hospital settings, where they were saying that when people are having examinations, particularly I think it was x-rays and scans done, that they were videoing the process, and there was concerns being raised by staff around that as well being shared. So saying, more or less saying that the trust, like every individual department nearly in a hospital has their own policy, and they're saying the trusts need to have a definitive policy in relation to this that just covers all healthcare settings, and which would hopefully also in some form include within the home birth.
Well, then I think what we should do then, just in the back of your comments, ask what the guidance is and policy in healthcare settings, but also how that applies in settings in home care, particularly with regard to giving birth. Everybody content? Okay, and then last and finally is, I think it's appropriate to raise the issue of the maternity hospital, given what we learned the other day. I referenced it yesterday, and people will remember our visit to the maternity hospital at the beginning of February, where certainly I was led to believe, and I thought we were all led to believe, that the news was going to be reasonably positive and that they were working towards a solution that was going to be becoming reasonably imminent and wasn't going to be that lengthy. So to hear the Minister say in the Chamber the other day that it's going to be 28 months, I think probably has knocked us all for six, on top of all the other problems that we have. Now, we will have heard the Minister saying that he is asking for clarification and asking for advice on option 2, why option 2, why others were against option 2, etc., etc. So, I mean, I'm not sure if that's going to actually delay the 28 months, or is that all fed into the 28-month time frame that he was given. So I would be suggesting, just given our concerns, that we write to the department, and that either through the department or the trust, that we actually be provided with a detailed plan of what's happening, why it's happening, when it's happening, and the potential costs of it, so that we are in a better place to understand exactly all of this issue.
Great.
Dan?
Yes, thank you, Chair. So just further to that, a couple of things that arise really from last week in the committee and the Minister's answer in the House, which I think are really, really important. Number one, is there any way we can see what the Trust is recommending while the Minister considers it, or is that off limits? For example, I mean, I think it all raises a huge number of questions. So, for example, a discrete water system for the neonatal unit. I'm presuming that means a separate water system for the neonatal unit, with the pipework replaced and a full replacement. Does that mean then that the rest of the hospital would not have Pseudomonas colonized in its water system? And if so, what's the risk if it doesn't mean that the rest of the hospital would have Pseudomonas colonized in its water system? I think there's a huge number of questions, really, even around the three options. And clearly the Minister has very grave concerns as well. So I think that's the first point I'd like to make. The second point I'd like to make, and I do think I would be really grateful if the committee would write about this. On 2 occasions last week, I asked the Trust management, were there any other surprises in store? Would we actually not have this scenario again? And then I found out, well, actually, Fire Service have escalated their concerns over 2 wards, and the Minister gave this information in the Chamber, have escalated their concerns over 2 wards of unsafe exit routes, and that those concerns were of such a nature as to be at the level where enforcement action would be taken against the Trust. That's really serious stuff. Really, really serious stuff. And it's not an event. This just didn't happen. This has been talked about. I mean, I'm presuming that Fire Service inspect, raise their concerns, re-inspect, give advice, etc. It's a long process till we get to this stage. So perhaps maybe we should actually be writing to the Trust and asking them to explain this fully, and whether or not they have now resolved the issue. I think that is an important one. And I suppose just related, maybe tangential to it, but in my mind from last week's evidence, is the fact that they said that, I can't remember which one of the Trust managers said, that the whistleblowing manager in the Trust reported to HR. I don't know about procedures in the Trust, but I was wondering, is that normal? Because whistleblowing is a separate legal process with anonymity built into that process.
Yeah.
And I was wondering, is that normal? And if it is not normal, why? I mean, maybe we can get some advice on it, because it does seem to me that some people, and Michael McKenna gave evidence from another trust in another interview later on in the week, about the difficulties even with the whistleblowing process. So just it occurred to me when I was listening to that interview that I don't know whether that is normal procedure or whether the whistleblowing manager should be a separate person and not reporting to HR.
Yeah, I mean, I don't see any issue with any of the committee writing on those on the basis of that. I mean, people will have seen in the table papers the terms of reference for Peter McBride. I mean, and it's talking about the assessing the effectiveness of and staff confidence in Belfast Trust whistleblowing and other reporting processes. So I imagine, I mean, we should write and get an assessment of it, but I imagine he's certainly going to be looking at how effective it is and how confident staff are that it's working properly. So is everybody happy enough with all of that? Okay, Danny, you wanted to come in?
Yeah, just briefly, just to agree with what Diane was saying about the maternity hospital, and the Minister did say the briefing that he had got would be shared with the committee.
Yeah.
So we should be getting that, and I think Linda had asked him specifically just about recouping of some of the public money that was spent on it. And he'd also suggested that he was looking into what parts of the hospital could be opened without being impacted by the other bit of the defective motorway. So I think we should be asking those questions as well.
Yeah. I mean, I think what we all want to see is the hospital opened as safely and as soon as possible. For us as a committee, you know, we need information so that we can be satisfied that the trust and the department are working effectively to ensure that that is the case, because we have a state-of-the-art hospital there that nobody can use staff-wise, and mother and children who absolutely need it. So I think that's the first priority. Okay, just moving on then, members, so we're just going to go draft minutes. Draft minutes of the meeting held on 12th of June 2025 are at page 6. Everybody content with them? Okay, thank you. Matters arising? None. Okay, so number 5 on our agenda is oral evidence on the inquiry on access to palliative care services. So can I refer members to tab 5 of our pack? There's a clerk's memo, page 18, and witness speaking notes are from page 5 of table papers. And can I welcome representatives from NI Hospice and the Children's Hospice. So we have Trevor McCartney, Chief Executive, Brian Henderson, Chief Finance Officer, Gemma Aspinall, Director of Care and Quality Governance, and Dr. Emma Lundy, Consultant in Palliative Care Medicine. So these are all very, very welcome. And can I thank, before you start, for the hospice for having us there in November and February. I wasn't there in November, but I was there in February. I think it might have been potentially my first visit when I took over as chair of the committee. So both visits were very informative for the inquiry, and I welcome you to the committee today in what is Children's Hospice Week. So I'm going to hand over to yourselves then to give us a brief statement, and then we'll ask questions.
Okay, thank you for having us. Chair, members of the committee, thank you for the opportunity to speak today, and also for the time that you've taken to visit both our adult and our children's hospices to see firsthand the work we do, and most importantly, the patients for whom we care. I'll say a few words, followed by my colleagues who join me today. Brian Henderson, our Chief Finance Officer, will speak to the realities of our current financial situation and the difference our funding would make. You will hear from Dr. Emma Lundy, one of our palliative medicine consultants in our adult inpatient unit. Emma will describe the nature and the impact of our adult hospice inpatient services and the types of patients we care for, and in particular, the difference we make to those patients and their loved ones. Gemma Aspinall, our Director of Care, will talk about the specialist nature of the care we provide. Gemma will also cover the services provided in our children's hospice, the only children's hospice in Northern Ireland, and also our adult community services and the vitally important role they play caring for people in their own homes. We'll then welcome any questions you may have. Through this inquiry, you have heard many of the facts, figures, system failures and issues facing palliative care, all of which we echo and all of which are absolutely correct. My colleagues will reinforce many of those messages today. However, we also want to talk about our patients to help bring out the reality of what palliative patients and their families face and the difference hospice care can make, whether it's part of an inpatient service, in the community, or any combination thereof. Patients are at the heart of what we do, something we never forget, and we want to ensure their voice and their needs and those of their loved ones are brought to members of this committee. With that in mind, I want to give you some brief comments, both from a patient and from a patient's family, that are very representative of the feedback we receive every single day. There are simply no words to describe the gratitude I feel towards each of you who have played some role in this incredible environment. I am able to walk out of here feeling like I have an abundance of quality of life, something I haven't had in so long. This is an important reality of specialist palliative care. Consultants like Emma and her colleagues are highly skilled and capable of managing very complex patients. Our patients are very often discharged back into the community. Many patients have multiple admissions to our inpatient unit to resolve symptoms and do go home each time. That is a true benefit of a specialist service led by specialist consultants supported by a specialist community team. In terms of the families, here's a quote that always sticks with me. You all made what was a tremendously difficult time much easier. The care and compassion that you all provided in those last weeks of our life was second to none and made the process less scary, not only for our loved one, but for us as a family. We're the last hospice to give evidence as part of this inquiry, and the truth is, all hospices want exactly the same things: fair and secure multi-year funding, a clear and deliverable strategy that will deliver a best practice service model, hospice inclusion in strategic healthcare planning, a region-wide approach to palliative care that reaches everyone who needs a service, regardless of where they live, a clinical lead with the authority and mandate to drive this forward. These are not luxuries. They are not a nice to do. They are a minimum standard in a compassionate health system. A very eminent physician said something to me recently that really struck me. He said, Northern Ireland is small enough to have one of the best health systems in the world. I do believe that is possible, but it requires focused minds, courage, and actions that result in outcomes rather than continual reviews that move our services no further forward. It requires an uncompromising focus on patients and their care. As the only provider of children's hospice services in Northern Ireland, we'll be giving you insights into how that care is currently provided, what it costs, and what it would mean for our patients and their families if we got the government support that we need to provide the level of care those families deserve. With that in mind, it may surprise the committee to know that the recently defined baseline scoping work to understand palliative care need, work that has not yet begun, has, at its earliest stage of development, specifically excluded children's services, a matter which causes us great concern. Hospice care, be that in the community or in our adult or children's inpatient units, is not about people dying. It's about living well, right to the end. We may not be able to add days to life, but we can and do add life to days. Northern Ireland Hospice cares for people physically, emotionally and spiritually, providing vital support to our patients and their families, and we do it every single day under growing pressure with unsustainable funding and a system that still treats us and those for whom we care as optional. Let me be clear. Palliative care is not a luxury, it is a human right. And right now, too many people in Northern Ireland are dying without the dignity, comfort, or the support they need and deserve. We're not asking for special treatment, we're asking for fairness. We're asking for a model of care that recognises hospices as essential partners in the health system, not as afterthoughts, not as nice-to-haves. We've worked very hard to make ends meet and are so grateful to our philanthropists, local and international, and the wonderful Northern Ireland public without whom we wouldn't be here. However, relying so heavily on these sources for funding instead of government is a failure we can no longer afford when everyone deserves compassion in the final stages of their lives. This inquiry may be the start of us building something better, but talk won't ease pain. That will only come from meaningful action. Thank you. Brian.
Chair, members of the committee, good afternoon, and thank you for the opportunity to speak today. As Chief Financial Officer, I must begin by addressing a critical and growing concern. In 2004, the Department of Health committed to a 50-50 funding model, whereby statutory funding should meet 50% of the costs of charitable hospice care. Unfortunately, this commitment has not been met in either our adults or children's services in several years. Based on our current forecasts, we estimate the funding gap required to meet the benchmark will be approximately £805,000 in the current financial year. At the root of this funding gap is the decision that the Department of Health initially made to benchmark hospice funding against the cost of a general medical bed, a standard which fails to reflect the complexity of the care we deliver. General care addresses a broad range of health needs across the population, while specialist palliative care focuses specifically on people with complex, life-limiting conditions, providing expert symptom management, emotional support, and end-of-life care through a multidisciplinary team. Our hospice provides this high level of specialist care to the overwhelming majority of our inpatients, yet we are funded as if we are delivering generalist support, leading to a deep and growing disconnect between the care we deliver and the funding we receive. This shortfall has only increased year on year, particularly since the onset of COVID-19, as we have faced extraordinary cost pressures, including rapidly rising salaries, medical supplies, and energy costs. What are the other challenges that we face? In addition to the well-documented cost pressures arising from inflation, we have faced a significant increase in employer costs due to national policy changes. The rise in national living wage by 6.74%, combined with the increase in employers' national insurance rate and the reduction of the employer's allowance threshold to £5,000, has resulted in an estimated additional cost burden of approximately £500,000 across our organisation. Against this, we received total interim uplifts in statutory funding of just £196,000, and while this funding is very welcome, this disparity further widens our funding deficit, undermines our sustainability of our model, and leaves us struggling to find an additional £304,000. Despite our statutory partners relying on us to deliver complex end-of-life care in the community, we rely heavily on fundraising from the general public to cover the gap between statutory funding and the full cost of our charitable activities. This shortfall has become increasingly difficult to bridge in recent years. According to the Consumer Council's Household Expenditure Tracker at the end of 2024, the lowest income households now have less than £53 per week discretionary income after essentials, an 18% fall since the first quarter of 2021. Even modest increases in food, utilities and transport significantly impact household budgets and reduce their ability for charitable donations. In spite of these challenges, and to remain operational, we have responded proactively. Over the past 2 years, we have achieved record highs in both voluntary fundraising and retail trading from our hospice shops, through a clear strategy of income diversification and organisational growth. To their immense credit, the fundraising and retail teams have performed remarkably, despite the immense pressures on disposable household incomes during the ongoing cost of living crisis, achieving just over £10 million in income combined last year. It is also worth noting that our fundraising and retail teams consistently outperform hospice UK benchmarks for return on investment and profit per shop. Yet, even after surpassing all previous income benchmarks, we still recorded an overall deficit. This underscores a hard truth. Specialist palliative care cannot be sustained through charitable income alone. Last year, the public gifted £2.72 million to the NI Hospice through legacies, donations left to us in their wills. which accounted for approximately 14% of our total income. And while these donations are very welcome and ultimately reflect the high regard in which the public value our services, their timing is unpredictable and therefore cannot be relied upon year on year to fund our largest ongoing cost, our staff salaries. Are these pressures unique to Northern Ireland Hospice or part of a larger trend? As a member of Hospice UK, we submit detailed financial performance reports on a quarterly basis and receive sector-wide benchmarking data in return. These reports highlight that the hospice sector as a whole has suffered collective operating deficits over the past 2 financial years. The only deficits in over 20 years of Hospice UK collating the data, and therefore the worst results on record. The report also noted that the largest pressure across the sector was pay, with payroll costs increasing by 9% last year. When combined with a 10% increase in the year before that, this shows the hospice sector has seen a wage bill rise by almost 20% in 2 years. The data indicates the stark reality that the situation is rapidly deteriorating for all UK hospices. Aside from the funding gap, I now want to talk about statutory contracts. One of the key challenges we face with our statutory contracts is the lack of standardisation across the different health and social care trusts. The inconsistency results in variable contract terms, funding levels, and reporting requirements, which complicates planning, service delivery, and financial sustainability. A more uniform contractual framework would help us ensure equitable support for hospice services across Northern Ireland and enable more efficient resource allocation. What would our ideal statutory contract look like? It would have 5 components. Number 1, multi-year contract awards to support strategic and workforce planning. 2, service-specific performance KPIs to reflect actual delivery and quality outcomes. 3, full 50-50 statutory funding to meet the Department of Health's original commitment. 4, indexation to the NHS Agenda for Change pay framework to ensure pay parity and financial sustainability. 5, a mechanism defined for overperformance to account for unanticipated increases in service demand. The question you'll ask, are these components practical and achievable? And the answer is yes. We achieved 4 of the 5 components with our patient-focused and forward-thinking partner, the Northern Trust. After reviewing the contract at the end of 23-24, new performance KPIs were agreed across the 3 service areas. The contract was increased by 25.6% to bring it up to 50-50 funding of our charitable costs. Contract duration was increased to 5 years, linked to Agenda for Change uplifts, with the 5.5% being paid to hospice in the same month as it was paid to NHS staff in March 25, allowing us to pay our staff in line with NHS. The simple truth is, we cannot continue to bridge a structural funding gap of this scale indefinitely. While maintaining current service levels, I would ask the committee to consider the following actions. Number 1, address the current gap to 50-50 for all hospices. For us, that would mean providing funding for £805,000. Number 2, recommend that the cost base of each hospice bed be assessed on the basis of the kind of care that is provided. In our case, specialist palliative care. To arrive at a service specification which would then be used as a benchmark for calculating funding going forward, initially at 50-50 with a gradual increase to 100% over time, as is the case with the Republic of Ireland. Number 3, recommend that statutory contracts be standardised across the various trusts to include at least the 5 aforementioned key components. Without a fundamental shift in the funding model, one that aligns statutory contributions with the true cost of specialist care, we risk the erosion of a service that is essential to our communities and then valuable to the patients and families we serve. We welcome this inquiry as a vital step towards creating a more sustainable and equitable model for palliative care in Northern Ireland. Thank you.
Chair, members of the committee, thank you. You'll have heard of lots of people who have come before me define what specialist palliative care is. I'm not going to do that again. For me, it's the same as referring to any specialist service. When the generalists have done everything they can for a patient and it isn't working, they refer to the specialist in that area. The same as general surgery, cardiology, respiratory, renal, etc. But unlike those specialties, we don't perform life-saving surgery. We don't do procedures that improves the way your heart works. We don't give you dialysis that is life-saving for you. And let's face it, we talk a lot about death and dying. It's a real conversation stopper on a night out when somebody asks me what I work as. But in all seriousness, this reflects the attitude to death and dying in Northern Ireland. If we don't talk about it, it might never happen. But it does happen to everyone. Not every person who is dying will need our help, but we need to be able to reach those who do. We are made to feel like a luxury specialty instead of an essential one, and it feels like we are constantly fighting for recognition and funding. As sad as it is, I sometimes think that people will only understand our true value when you have had to access our service for yourself or for someone that you love. Or maybe, sadly, it's when you or someone you love need us and we're not there. Everyone is entitled to high quality, palliative and end-of-life care. People do not need to suffer unbearable symptoms. People do not need to die badly, agitated and in distress. But when we cannot reach them, sadly, this is what can and does happen. We constantly have a waiting list for our inpatient unit, which means there are always people who are suffering waiting for our beds. Sadly, some of those patients will die before a bed ever becomes available. Our inpatients cannot receive the specialist care they need anywhere else, exactly the same as patients in an intensive care unit or coronary care. Just because it's not life-saving treatment, it does not mean it is of lesser value. The good news is, and I know that I'm biased, we provide excellent specialist palliative care in Northern Ireland Hospice. For me, it is a blessing to walk out of your place of work every day and be immensely proud of the care that we provide. Please help us deliver this care to the people who need us the most. In relation to the bigger picture of healthcare in Northern Ireland, specialist palliative care has a significant role to play in the strategy of right patient, right place, right time. We can help prevent hospital admissions and expedite patients' discharge home from hospital by providing specialist palliative care for patients in their own home. We can transfer patients with specialist needs out of the acute hospital to our inpatient unit, thus helping to free up an acute hospital bed. We have 18 beds, and we fall victim to the same issues that the hospitals face. We struggle to get the social care support for our own patients who are ready to be discharged from hospice. And as a result, our beds do not become available in a timely fashion for those patients who need them the most. This also has implications for respecting a patient's preferred place of care and death. It is dreadful to tell a family that we cannot get the social support they need to get their loved one home to die in their own home. This lives with families forever, that they did not grant that one final wish. Could we get the same access to packages of care, step-down beds and nursing home beds as the Trust, so that we can have the right patient in our bed at the right time? Let me leave you with a few examples of the types of patients that we care for. Patients who are so sore that they cannot sit down and they scream in agony if they try to. Patients who have severe symptoms, are dying and have young children. Patients who have tumours eroding into their face, they cannot speak, eat or breathe normally and they have severe pain. Patients who have severe symptoms and have a history of alcohol or drug misuse. Patients who have been in prison and have been compassionately released or transferred to us for end-of-life care. Patients who have severe symptoms and are dying and have come through the legacy of the Troubles and have severe psychological distress. My last question to you is, where else can these patients get the level of care they need and deserve? Thank you.
Thank you for prioritising palliative care and for the opportunity to contribute today. I want to start by remembering we have a lot to be proud of. At Northern Ireland Hospice, what we do incredibly well. But it is not enough, and we want to do more for more people. We need fair and sustainable funding based on need and service delivery costs to do this. At an individual nation level, Northern Ireland is projected to have the largest proportional increase in need for palliative care, rising by 32% between 2023 and 2048. This places the largest change in demand on the services needed to deliver the high quality, compassionate care that is needed and that which everyone who requires it deserves. It is a demand on services which are highly fragmented, a symptom of complicated commissioning, regional variation, the lack of a regional service specification, and an absence of fair and equitable funding. In facing this challenge, we would all like to hear that we have a head start in the marathon required to deliver the services needed across the region. In reality, if we ask those nations to take a step forward if they have an up-to-date palliative care strategy, a legal right to access palliative care, fair and sustainable funding for hospice services, or clear service specifications to inform commissioning and service delivery, then we find ourselves firmly stuck on the start line, an outlier lagging behind the rest of the UK and Republic of Ireland head starts, when we should be aiming to be at least equal, if not the best. Furthermore, hospices are under greater pressure than ever before to find ways to do more with less. I'm going to talk a little about our adult community services. More than 95% of our adult hospice services are delivered outside of our hospice buildings, and most people we care for want to remain at home, in the comfort of familiar surroundings and the presence of their loved ones. Last year, we helped over 1,500 patients fulfil their wishes to die at home, supported by our specialist community nursing team in partnership with GPs, district nursing, family members and carers, and our hospice at home team. Every person cared for needs and deserves high-level support and care to achieve this in comfort and with dignity. Our hospice community nurses are more than healthcare professionals. They are a lifeline. They step into people's homes during the hardest days of their lives. Their care and responsiveness helps prevent and manage crisis and eases health service pressures elsewhere by avoiding unnecessary hospital admissions, visits to the emergency department, and calls from the ambulance service. To add context, if one person were to spend their final days in hospital, a conservative cost estimate would be approximately £566 per bed night. Now that's based on a very old benchmark figure, for 3 nights. This would equate to just under £1,700. For all people supported by our teams in the community at the end of life, this is comparable to over £2.5 million savings to the acute health and social care system. Using similar methodology, 5,406 bed nights occupied in our specialist adult inpatient unit represents a cost saving to the acute trust of over £3 million. I will now move on to our children's services. Our Children's Hospice is the only provider of children's hospice services in Northern Ireland, offering comprehensive paediatric palliative care that supports not only the child but their entire family, physically, emotionally, spiritually and socially. Every child we care for is unique, and our goal is to enhance their quality of life by creating opportunities for meaningful moments and ensuring they receive the right care at the right time and in the right place. At Horizon House, our children's inpatient unit, this last year 233 children were cared for during supported short stays, and unimaginably 10 children were admitted for end-of-life care. It may shock you to hear, but this 10-bedded unit has never been able to operate at full capacity due to insufficient funding. With the right funding support, stepping up from the 6 beds we can currently afford to operate up to a full 10 beds would make the world of difference to the children and families we care for, increasing access to and the length of supported short breaks, and ensuring that we can respond to both end-of-life and social emergency care without impacting the planned supported short breaks for other children. Currently, we can offer on average less than half the number of days that the Children's Hospice in Dublin can offer to each child per year. As a nation, we fall short when benchmarking our paediatric palliative care provision against others. To help address this, the Paediatric Palliative Care Network needs allocated resources to make improvements, and the future recruited palliative care consultant to lead a regionalised approach, alongside other disciplines, to provide one clear model of care across the region. In the last year, we supported 16 antenatal mothers whose babies had been diagnosed with life-limiting or life-threatening conditions, and our Hospice at Home team provided over 6,000 hours of home-based nursing care to 52 children. Parents tell us that this service is invaluable in helping them balance day-to-day life around their child's complex needs, providing them the support that allows them opportunity to spend time with each other and their other children, and helping to reduce the potential impact of adverse childhood experiences. In the Regional Hospital for Sick Children, our palliative and life-limited service nurse, offers crucial support to families during the most challenging conversations, breaking bad news, advanced care planning, and making decisions about where to receive care. We know that a child's illness affects the whole family, and our family support team provides emotional, practical, and social support to the entire family circle, including siblings and grandparents. For those grieving the unimaginable loss of a child, our specialised bereavement support is there to offer comfort and guidance. The Horizon Bereavement Project, now in its 4th year, is reliant on non-recurrent funding and has provided bereavement support to families who have experienced the sudden and often traumatic death of a child, helping them to find solace and strength as they process their grief. The truth is, across our children's and adult hospices, we offer vital services that people hope never to need, but it is crucial we are there for those times of need when they do. What is our ask? I would ask that we put a stop to the inertia, to stop repeating reviews and issuing recommendations that are not underpinned by mandated actions and appropriate funding. That there is action now, and a commitment to ongoing action to sustain, deliver, and further develop the delivery of palliative care to all those who need it in Northern Ireland. To fully fund hospice care for adults and children, recognising its crucial role in palliative and end-of-life care delivery within the wider health and social care system. That there is a clear regional service specification for palliative and specialist palliative care services, including 7-day service provision and out-of-hours services. For closer integration of palliative care across health and social care settings to ensure timely and effective care and avoid duplication. Through this, that everyone across the full lifespan in Northern Ireland can access equitable, high-quality palliative and end-of-life care, no matter who they are, where they live, and regardless of the cause of their condition. That we give the people of Northern Ireland and the services who deliver palliative care for them a fair start in the race to achieve the very best for all the people who need it at their most vulnerable time, and that we take this chance to get it right. Thank you.
Okay, thank you. Sorry, excuse me. Thank you, all of you. I suppose I should put in record my mother was a patient in the NI Hospice over 20 years ago before coming home to die. So, I mean, from a personal point of view, I understand the great work that you do. So I'm just going to go straight into questions. Fair, secure, multi-year funding, I mean, sounds eminently sensible. There's a lot of detail in there. So 2004, there was an agreement where hospices were to get 50-50 funding. You're saying that isn't happening, and at the minute you're probably £805,000 short of that level. Yeah. Okay. So just kind of following on from that then, because I'm trying to get this right in my head, you're also saying then that you get funded nearly at the cost of what the department equates to a hospital bed in a hospital, which is general services, as opposed to the obvious increased costs where you're providing specialist service. I mean, what is the kind of gap in terms of a hospital bed versus the cost of a palliative care bed in a hospice?
To give you a little bit of background to this, you're right. In 2004, there was an agreement, and the actual phrase in the agreement, it was a ministerial direction at the time, was 50% of hospices' cost to provide care. So it wasn't based on a benchmark, it was supposed to be an assessment of each hospice's funding structure, because every organisation is different, and 50% of that was to be paid. In 2018, there was a review done, and the decision was made at that point to benchmark it on that 50% on the cost of a general medical bed at that point in time in 2018, and we were getting paid 50% of that. 50% of that is not close to 50% of our costs, and here's a reality. I have 18 beds in an adult inpatient unit and 6 beds in a children's unit. If I look at that, I don't have a big volume of beds to spread that overhead over. So the NHS, even for that benchmark, has thousands of beds that they can spread that overhead over. So it was never going to meet that 50% level. That was never going to happen. As each year has ticked by, there are small uplifts given, but those small uplifts don't actually close the gap. They widen the gap because they're not in line with inflation. But what we have seen, and the Northern Trust is a brilliant example of this, the Northern Trust reviewed our contract. Why did they do that? They're very forward thinking. They know they have one of the greatest ageing populations in Northern Ireland, so they knew they needed to manage those services in a way that they would become sustainable. So as Brian went through, they have linked their increases, first of all, to 50%, so they pay actually 50% of what the cost is. Where those costs increase, they've linked that to pay rises in the NHS, so it's linked to Agenda for Change, so that stops the jaws widening. And they've based it on ensuring that they get the service they've paid for, which is a sound business approach to a very difficult situation. And where there's overperformance, we can have conversations with those. But that money is the same money any other trust will get, because they get that from SPPG. So my question becomes, if we know that's the way forward, and we've seen examples as to why that is the case and why it works and can work, why can't all funding be that? Now, the final point I'll make on that is that's the 50% argument. But the reality here is, and Brian has talked about it already, with the cost increases across the UK and various other things, the benchmarks that we get at the minute, even if it was 50%, will not be enough in the long term. So we do need to move towards a more capable funding model that goes far beyond the 50%.
Okay. And as a citizen of the Northern Trust, I'm delighted to hear that the Northern Trust are, it's actually great when we actually hear people come and give an evidence where they're able to pinpoint where something has actually been done well. I mean, we're very interested across all health, but particularly in this inquiry on health inequalities. And I mean, obviously, to tackle health inequalities, you need to tackle funding inequalities too. So this is very, very important. So again, I'm just trying to get this in my head. So you're saying 50-50. I mean, when you're describing the scenario and how we've got to here, and I'm trying to use my words very carefully that I don't insult anybody, but it nearly seems like it's a business trying to save money rather than worried about patient outcomes, as you would expect the Department of Health to be worried about.
I think it was twofold. I think it was a very easy way to put a measure in place that some may regard as defensible. I regard it as indefensible. So from a governance perspective, maybe that was an easier solution, but the reality is, first of all, bears no resemblance to the agreement that was already in place, so that's not being honoured. And secondly, it does not meet the cost base of any hospice in Northern Ireland. The result of that is every hospice is showing deficits.
Okay, I mean, I could carry this conversation on for a long time, but you have been very good in terms of the evidence you've presented with us, so I'm going to move on. Just in terms of the exclusion of children's services from the scoping exercise, what's the impact of that going to be on?
So we were invited to a meeting recently with SPPG to talk about the baseline scoping exercise, and as you'll be aware, that baseline scoping exercise was committed to a long time ago. It was supposed to commence 6 months ago. It clearly hasn't. So the conversation, we went through some slides on it, but the conversation was the extent to which that piece of work was going to be de-scoped to the available data, and even then some of the data isn't available in order to get something moving. But when I saw on one of the slides that children's services had actually been de-scoped from it, I was appalled. If you look at children's services in Northern Ireland, it's a need that's growing, not reducing. So to de-scope it out of that was really quite a surprise. So I wrote to children's commissioners and asked them if they were aware that it had been de-scoped, and they replied in a very timely way yesterday. and said, yes, they were aware it had been de-scoped and that they were trying to find resources to look at that. But that really doesn't help, because if there's a big piece of work happening to look at palliative care within Northern Ireland, it should absolutely be part of that.
Yeah, no, couldn't agree more on that. And then maybe to Gemma, you talked about 24-hour services. So I mean, if it's obviously a significant issue that has been raised time and again, particularly by loved ones trying to access services. So I mean, if we could get 24 or 7 days a week services right across the board, how could hospices help, or how could they provide that assistance?
I think it's a big omission that we only provide services across 5 days a week. We know that they are much needed services. At the moment, that the funding certainly doesn't support 7-day out-of-hours service provision. Should that funding be there to support that, what we can do is provide that same response, to be there to respond to changing symptom needs, to help people manage to be cared for at home, and to provide timely and responsive care, so that what they don't do is end up picking up the phone to call NIAS. We don't present at the emergency department, but it requires appropriate workforce to deliver that. There is a piece being led, one of the work streams, by the Palliative Care in Partnership programme at the moment, around scoping 7-day service provision for specialist palliative care nursing. It will be absolutely imperative that that model, any recommendations that come from it, do actually specify the resource that's required to deliver it. I would have a concern that there may be a potential for a recommendation to stretch the service and the workforce that already exists more thinly to try to provide that. That would be extremely remiss of us. So we could be there to respond when people need us, not that things switch off at 5 o'clock on a Friday, not that doesn't resume in terms of a face-to-face service provision until Monday. At the moment, when somebody needs something out of hours, you will have generalist service providers responding, which is amazing. If there is 24/7 district nursing in an area, I will add, it is not available in all areas of Northern Ireland. That's excellent. There can be a physical response. However, what we would like to know is that those requiring that specialist level of support and that more complex symptom management, that they're getting the right person at the right place in the right time, which is a specialist nurse in their own home when it's needed.
Thank you. And then I'm not going to ask you a question, but I've underlined a number of points that you have made in your presentation, which I think are very, very important. I'm just going to throw it open to other members. Dan?
Yes, thank you, Chair. Trevor, can I go back to the issue of the children's services within the scoping exercise? I think we've asked this question numerous times in this committee. We asked the Royal College of GPs, had they been asked anything about the scoping exercise? They said no. You clearly have been to a meeting with SPPG about the scoping exercise, but are now telling us that actually it hasn't started. And quite frankly, I find that appalling. Right at the very beginning of this inquiry into palliative care services, we had a presentation from a senior official in the Department of Health who talked about a scoping exercise. And if we are 6 or 8 months down the line and this hasn't started, then that is actually appalling. It's appalling that the department doesn't know the extent of palliative care services out there, but it's equally appalling that they haven't started. So I'm really astounded by it all. I suppose it shouldn't be, really, to be honest. So 2 things that I want to know really is, it's really important. I know we'll discuss it as a committee, but I would hope we would write in the strongest possible terms and say that it is really unimaginable that children's hospice services could not be included in this. But what's the impact of it not being included?
The impact of it not being included is there is no definition as to the scale and scope of need, and therefore it's unlikely it will ever hit an individual's desk in SPPG or anywhere else to say, here is something you need to deal with. And the reality of the situation is this: if you take palliative care generally, the last palliative care strategy in place in Northern Ireland was in 2010, Living Matters, Dying Matters. It ran to 2015. There was then a commitment, New Decade, New Approach Action 13, which was to produce a strategy. So it was assumed that would happen. It didn't. There was then a reference in the Department of Health annual accounts, which was 2 years ago, maybe 3, saying there was a lack of resources to do that, but they would get to it. And then it literally disappeared. So the reality is palliative care, adults and children's, has not received the attention it needs because those strategies at a regional level have not been done. They are not in place, and key to any strategy is the data, the information, the insights that will actually lead to actions that can then be taken forward and appropriate funding can be sought for. That is the reality of where we are and have been for nearly a decade now.
Thank you for that. The other thing, back whenever, I can't remember now, the Minister announced an additional 13 million every year for additional respite beds. You potentially have 10 respite beds,
Yes.
but only 6 of those are you are able to fund and use. And I know personally and from families that I've been involved in how really, really important those beds are, either for children who are life limited or children who need care and respite. So one, were you ever approached with the production of the 13 million to consider opening more respite beds? What is the need for more respite beds? Do you have any data, any figures that we can have on that?
Yes.
What's the need for more respite beds? And what difference is that going to make to that child's life and its wider family?
I describe it to you this way. In terms of need, the benchmark, and Gemma will know more about this, but the benchmark is we should be able to provide every year at least 10 to 12 days respite care per child. With only 6 beds, we can only provide 5. So the result of that is we're in a situation where children will arrive with us, and if you see these children, and you've seen it, Diane, because you've been there and you've supported some of our families, these children arrive in huge people carriers with a myriad of equipment, and by the time they actually decamp to go in, they're only there for 2 days, they're going back out again. That's not an acceptable level of service. If we took it up to 10 beds, then we could achieve the 10 to 12 nights that we could potentially do. And when you look at some of the other issues that face Northern Ireland, we're quite a rural geography, and a lot of these children are coming from far away. So we used to have a 7th bed before that was cut, as you know, and the purpose of that was reserved for children who had to travel for more than an hour to get here. But that rurality is why we really need some of these beds to be expanded. Gemma, you may want to add to that.
Yeah, I suppose one of the things to highlight, so we supply supported short breaks to children. Increasing that bed capacity, I have to be clear, what it doesn't do is provide care for more children, because we do receive the referrals and accept the referrals that are relevant for our service and look after every child that is appropriate. What it does is ensure that they have longer stays, a higher number of stays across the year, and they get even that little step closer towards achieving what other nations can provide in terms of that supported short break provision. You heard me describe it as, parents describe that as a lifeline. It really is, to allow to do some simple day-to-day activities, to spend time with each other, with other children, and that is so, so valuable. So in terms of the actual impact, the impact is a longer stay in terms of a wider number of days across the breadth of the year. But as I said, we're on an average of 6, sometimes just below 6 across the year. That visit down south, both inspiring, uplifting and deflating in equal measures, because to hear that you can offer 15 nights on the same island, I think it's extremely sad that we come back to say, okay, we're in a situation where we can only offer much less. And I suppose it's going back to the opener. What we do incredibly well. We need to be able to do more of that for these children and families.
Diane, to answer your question, which I omitted, no, we have not been approached with any of the funding that was announced in any way.
Yeah. I think that is really important. It's tragic and it's a shocking omission from the department. I did write to the Minister about this and I got a letter back which said one trust had expressed some interest in it. If these really, really vulnerable children and their families are not a priority, I really fail to see who is a priority. And again, I think that is a matter that is really, really worth pursuing because I do think it is hugely, hugely important. I hear you in terms of the contracts, in terms of the funding. I think those are all really, really helpful suggestions and very important. And most people will have reiterated the issues around employer national insurance and the issue around equity in the provision of services for people with palliative care needs. Can I just ask as a last question, in light of the fact that tomorrow will be a really, really significant vote in Parliament, what is Hospice's view on the assisted dying bill?
We have literally just finished with our board a week or two ago in terms of developing our position, and it's very simple. And it is that in the Northern Ireland Hospice, our charitable objects do not include assisted dying. It is not something we do.
Can I say finally, thank you so much. I enjoyed and was enlightened with my visit to the hospital both times that we were there. I think it's really, really important. And the hospice movement across Northern Ireland is really significant and important. And also, I'm admitted to say, Chair, I was also there yesterday when the Southern Area Hospice became Evora Hospice Care. And I really do wish them all the best. I think it's really, really significant and important. So thank you for everything. Thank you.
Linda?
Thank you, Chair. Some of the points that I was going to ask have already been made. Just in terms of the scoping exercise, I mean, I don't think we can wait until this report's done and recommendations out of it. I think we need to ask now why our children's services been left out of this, because this is something I'm raising time and time again, even outside of palliative, but it includes palliative and the support that
Should mention we have SPPG here in 2 weeks, so we will be asking them next week.
I'm really frustrated across the piece at services for our children, and you talked about children where diagnosis has been given post birth, and them coming to you. You are probably all they have, because that's been my experience when I'm talking to families. When a child is diagnosed with anything, there is little to nothing, and we have young boys now who are just pre-teen or teenage who have DMD, muscular dystrophy, Duchenne, and there are no services. There are no counselling services for those young boys or for their families or for anybody. And all of this is just, to me, there is so gaps for children's services right across the piece. But that's really frustrating to hear that in this piece of scoping work being done, an opportunity to actually look at what is there, what's not there, what can we do better, to just completely leave it out. So I think we need to find that out. And I think most of my other questions, to be honest, have been asked and answered. So just to say, look, obviously, I mean, we appreciate what you do. I think just the consequences of not getting access are what people don't understand. And I can say, I mean, even though as a family we've been through it, and I've been through it in my broader family context, I watched a programme last night where it was based in England, where an elderly man, actually 80 years of age, with a severely disabled son, whose wife died, but he contacted hospice. They weren't able to help. They didn't have a bed. and she died of natural causes. He was arrested for potential murder. He didn't. She died not of natural causes, but he did attempt to take the life of himself and his son, because his view was there were no services there for my wife and to help us. So she asked him, she said, you know, there's nobody going to look after our son when we both die. So, and he was arrested and he went to jail for attempting to take the life of his son. So that's what happens when families don't get support. And I think that's probably the thing that we always miss. You know, it's we talk about what happens. And finally, just in terms of the lived experience, the people who we met with before the committee last week, that really highlighted the difference to me of those families and those individuals who required palliative care, the difference of those who got it and those who didn't, particularly around the pain management. That was the big issue, and I think that for that reason alone we really do need to, I think we've done the right thing in having a focus on this and doing this inquiry. Thank you to all of you.
Danny?
Thank you, Chair, and thank you for all those presentations. You know, that gives us a really comprehensive view of the amazing services and amazing work that you do. Obviously, most of us will be very aware, and the opportunity to visit your hospices was really, really moving. To see such a calm, quiet, peaceful, welcoming atmosphere, and to have the opportunity to talk to some of your patients and families, their appreciation for what was on offer, despite harrowing circumstances, it really does change people's lives. You know, it is incredibly powerful, so thank you for that. And one other thing, when I'm talking to people on the street, and I think you'd mentioned we're a small place here in Northern Ireland, nearly everybody knows of someone who has benefited. It'll be someone in their family or a neighbour or a friend. So there is, you know, there's a lot of appreciation for the services in Northern Ireland. Everybody knows. I think that probably reflects in what you were saying about the increased sales in hospice shops and the increase in donations. People really do appreciate it, you know, and it's the way it's funded is wrong, and absolutely we need to address that. But I think people really do get behind hospice. Trevor, we'd mentioned just about the children's services being excluded from the scoping exercise there. Just what Linda was talking about. Did they give you a reason? Did they give you a rationale?
The rationale appears to be that there is insufficient data, insufficient time and insufficient resources to do a scoping exercise of that breadth, and that would appear to be the reality that they're facing. In one way, I understand there are many challenges and issues in health, but my view is very simple, and I've carried it through my whole career, and it's an ethos in hospice. If you're going to do something, do it properly. And do it so that the right outcomes and the right insights develop the right actions that make a difference. So it is worrying that it's not included. And just, Linda, in terms of some of your earlier points about funding, you'll have seen in the past there was a debate on the floor of the Assembly about the funding for children's hospice. And the Minister had seen the hospice, he'd spent a lot of time there. And he is aware that we have philanthropists who are willing to fund additional beds if government are willing to step up for the additional 50%, and that was announced. The Minister mentioned it as part of that debate. So the reality is, we know the need is there right now. You know, that doesn't require a lot of data. We know that there is funding that can be made available in other respects. We know that our ask is probably significantly smaller than that, and that we have philanthropists, international philanthropists, who are willing to help. It just seems somewhat bizarre that with all that positive, clear information, we can't seem to move this one forward. And the other thing to remember as well is it takes time to build up a service. You know, you need the clarity of what you're going to do for a number of years to be able to recruit and retain and manage the individuals who are going to staff those beds. So really, delaying is not an option.
Just ask, and I know we've spoken about that before, the 50-50 funding is available at the minute. How much would that cost to come up to the full 10-bed funding?
It's a much better place to answer that.
So to come up to the full 10 beds, so essentially it would cost approximately 1.2 million extra a year. But what that would do, by increasing our capacity, as Gemma and Trevor said, for the stays, you get an economy of scale. So you take about at least 25% off of the cost per bed night to run.
And that's with the 50-50.
That would be on the basis that it would be 50% statutory funded within private donors as well.
You'd mentioned as well that you have an £805,000 deficit already this year.
That's planned that's what we deficit on our statutory funding in 25-26.
That equates to me, my maths might be a bit shaky on this, so I'll ask the chair or somebody to check it. 0.01% of the healthcare budget. So somebody else can check that, but it does seem quite, small. My question is, what happens if you don't get that funding, if that funding isn't raised through charitable donations or whatever else? Will this impact your reserves, or will this impact your ability to deliver services?
Yes. So from a sustainability point of view, this year was 25-26 is year 3 of our 5-year strategy. We had planned to break even, but the autumn budget put a large spanner in the works to the tune of almost £500,000. So we have projected a shortfall this year of £386,000, but that's because in the absence of 50-50 funding, we have grown our fundraising and retail side to essentially try to offset that. However, there's a limited amount of runway in that, as I was mentioning before about the diminishing discretionary incomes that households have. So while we are expanding shops, we are trying to offset the diminishing funding from statutory side. Again, that can only last for so long. As part of Hospice UK benchmarking, our average reserves would be sitting at about 5.8 months, and essentially the UK Hospice benchmarking was sitting at about 9 to 10. Now, as I said before, the last 2 years in the hospice benchmarking across the sector has seen 2 back-to-back deficits for the group. That means that every single hospice as a collective is eating into the reserves. That benchmark now sits at about 7 months, so they've lost approximately 3 months worth of reserves because of each deficit eats into your reserves. It's essentially eating into your savings. That can only be sustained for a period of time, and then you become insolvent, and then the support no longer exists for all these families.
So we're on a ticking clock effectively.
Yes.
That is being eaten down.
Right.
Yes. The reality of our strategy, we set a strategy 2 years ago because at that stage it really was a very difficult time for us financially. So we had to be very clear about what we did, and the strategy in summation is simple. If we're not breaking even, we have to look at what we do in terms of rolling back services, because you can't do what you can't afford. That's the reality of what we're facing into, and that's a devastating place to be, because when you need to roll back services to achieve savings to try and break even, it typically tends to be disproportionate to achieve the net benefit, because you'll lose some statutory income, you'll potentially lose some fundraising income. It can be very disproportionate, so it's not where we want to be. Your point is very well made about how small the amount of money is to make a difference right now, to then put us on a trajectory where we could get a strategy across Northern Ireland, which would lead to a funding model that will be sustainable, because certainly it isn't now.
Thank you. And my last question was just for Gemma. Gemma, you had mentioned the 7-day-a-week service, and absolutely, we've heard that time and time again here, where patients after 5 o'clock on a Friday then can't access anything, and if it's a bank holiday weekend, we're talking Tuesday, it can be quite a long sustained period of time, and that results then in inappropriate admissions to hospitals. Ambulance service have to come out to take the patient into A&E and then via into a hospital ward. It occurred to me that there must be savings then that would be quantifiable if you were able to do that. Is that in part of your calculation as well?
Yeah, I mean, very similar in terms of if you look at the estimated, bed night cost I used earlier, and the reason I stressed that was an old figure was because actually it's very conservative. It would be a higher cost now. Very similar if you were to cost an ED attendance, that would be easy to calculate that up.
Ambulance service.
Yeah, in terms of ambulance service, ED attendance, the vast majority of ED attendances will then convert into an admission. It's very difficult to get somebody home instantly if they're presenting in that manner. I think one of the things to say is that there are vast numbers of people being cared for at home who, despite specialist services not operating 7 days a week, can have their needs met very well by the district nurse key worker and by GP service out of hours. But when those needs become more complicated and you need that extra input, that's where the input of our services really comes to life. It's very unusual. If you look across the water, look at England in terms of development of 7-day services is commonplace. It's very unusual to have the lack of that provision in such key services. But it's not difficult to quantify, no, in terms of we record, from every intervention. If we carry out a visit, we go to see somebody at home in terms of whether that's helping to reduce their pain, making recommendations about changes to medications, advising about the use of syringe drivers. Really, you're there to prevent or de-escalate a crisis. And if we think every time that happens, the only outcome, if you're not there, is that somebody else needs to pick that up. And ultimately, it'll end up in a hospital setting. And let's face it, the system's beyond creaking. I mean, I had I would say misfortune because of the situation of needing to use the emergency department in the last number of weeks. And I worked in an emergency department myself for nearly 5 years, and it was still a real eye-opener. I could not believe in terms of how slowed down flow is through the system and the significant levels of pressure that they're operating under. Anything we can do to help prevent that happening, one, that's the system side of it. From a people side of it, as somebody wanting to be cared for at home, do you know, it's an absolute travesty to think that where you will end up is in that department where you don't need to be. Somebody else could meet your needs if we had the right system in place. And let's face it, your experience is going to be entirely different. And it's not because anybody sets out to deliver a less than optimum service. If you want to be cared for at home, you should be cared for at home.
Absolutely. And for somebody with palliative care needs to be brought into an environment, as you say, it's overcrowded, very noisy, very busy, long
distressing,
waits,
potentially in the last days of your life.
Yeah.
Do you know, it is.
But also, with people who can't meet their needs, people who don't have time, don't have skills, they can't meet their needs. So, it's not even that they go in there and it's a busy place and it's a noisy place. They go in there and they're put in a corridor and people can't get to them. The nurses are so busy, the doctors are so busy, they're left. So you think of patients in a pain crisis at home that have nowhere else to go but ED. They don't get the help they need in ED, they just move to a different place. So it is so badly the wrong place for our patients, and it's so unnecessary. And things fall back to GPs. We ask them to try to help keep patients at home. They can't. They don't have the time to spend with our patients at the weekend or out of hours. So, I mean, they're so busy as well. But it's somewhere where we can help. We do have the skills. We do have the time. We can help them. We can keep them at home, and that makes such a difference to patients and their families.
Clearly, that space, the growth of that service has huge benefits for patients, family, and the whole system at large. So, thank you very much.
Alan Robinson.
Well, thanks, Chair. Look, essentially, my question was very similar to Danny's with regards to the last visit that we had to the Children's Hospice. You had very kindly presented to us, Trevor, and you had gave us very stark figures of a funding gap to the tune of like 1.2 million. Yep. And was to ask how that was addressed, and also how you intended to address the £805,000 estimated gap in funding. And I think you've given Danny a pretty good response there. And I suppose just on the back of that, similar to Danny, that in the grand scheme of an £8.4 billion health budget, those figures there just aren't insurmountable, given the benefits that will flow from it. And I just also ask, and it's good to hear, as the Chair had said, that the Northern Trust are a friendly partner to you and a forward-thinking partner, and similar to the Chair, I live in and represent a part of the Northern Trust, and it is good, it is positive to hear that. But it begs the question, if they are a friendly partner and a forward-thinking partner, why are the other trusts not? And it begs the question, what is their response?
We have the same question, Alan, and we have not had an answer to that. We tend to go round and round the same circles. But you're right, the reality is, and Emma mentioned it earlier, right patient in the right place at the right time is what benefits everybody. And we live in a world now where corridor nurse is a job title, and typically that's where a palliative patient will end up and probably not be cared for. Would it not be better to properly assess the need, the demand across all the trusts, properly put in place the funding for all hospices to make sure that we can meet that need and thereby avoid pain for the patients, put them in the right place of care, give them the right treatment for what is essentially an incredibly small amount of money, disproportionate to the 8 billion or so that is the National Health budget for Northern Ireland. It would be a disproportionate benefit for a very small amount of money.
In a nutshell.
We have had some progress. It was small. So from an adult community services perspective, we have 2 commissioning partners, of which the Northern Trust is one. And Brian talked about all the benefits of what we achieved there in that rebasing of the contract. And it was excellent partnership working because we're on the same page about trying to provide the best possible specialist palliative care in the community. Our other commissioning partner did help in terms of increasing capacity across 4 other teams that we deliver. And that was a key change to be able to improve that capacity. But unfortunately for us, the actual continued funding shortfall meant that we ultimately end up with a shortfall again to fund from a hospice perspective to provide that. So although we had a small increase in capacity, we've not had the changes in funding to ultimately support our 50-50 delivery of care. I've been at Northern Ireland Hospice for 7 years, and the community teams and the specialist teams, all our inpatient teams, everyone you meet are absolutely incredible. But you do feel like you've been selling hope that whole time. Do you know, we talk about gathering the data, we demonstrate our impact and outcomes, we turn up at our commissioning meetings, we sell that vision, we show the impact of the services we have. I find it incredibly difficult compared to the setting I worked in across the water. In terms of commissioning changes, if we could show the impact of a service, demonstrate clear patient outcomes and actually very cost-effective services, actually the changes were relatively quick and I want to say easy. Having spent 7 years working through that, it took a long time, but we've seen some good progress. That Northern Trust change is very significant. But it becomes harder to sell that hope. When you've got people who come to deliver the best possible care every day, do you know, there's a huge pressure for us as well around maintaining staff well-being and making sure we avoid that moral injury. It's very different delivering a service where the outcome of you not arriving is somebody could die badly. It's very different to there may be an extra week, month, year for outpatient services, all of which are impactful. But actually the staff find that very difficult. And I do think we do need to talk about that because in terms of the ability to retain what we've already got, that gets harder and harder every year that we don't see changes.
That's a very good point to end on. I just want to thank all of you for the visits and for providing us with evidence during our consultation, for coming before us today and answering our questions. It has been very, very informative and useful. And I say this to all our witnesses, we hope that when we produce this inquiry, it does justice to the work and the impact that you make out there. So thank you.
Thank you very much. Thank you for your time.
Okay, members, moving on then to item number 6, SL1 from the Pharmaceutical Society. Can I refer members to papers at tab 6? So SL1 from the Society is at page 57 and there's a draft SR at page 60. And we'll just wait on the changeover. It's maybe not there, is it? Hope Diane's using this wee break to feed her dog.
Taking a walk.
Okay, so just going to welcome Canis Ward, who's the Chief Executive Officer of the Pharmaceutical Society. So, Canis, thank you very much. You provided us with papers. If you want to give a brief description of the intention of the SL, and then we can ask questions if need be.
Thanks, Chair. Deputy Chairperson and members of the committee. As the Chair said, my name is Canis Ward. I'm currently the Chief Executive Officer of the Pharmaceutical Society of Northern Ireland. Thanks for inviting us to give evidence today at the committee. I had hoped to be joined by our President, Dr. Geraldine O'Hare. I know some of you have met Geraldine previously in her capacity as President, but unfortunately Geraldine's otherwise engaged and does send her apologies. So stuck with me today. A bit of background on who the Pharmaceutical Society NI is. The Society was established by the Pharmacy and Poisons Act in Northern Ireland of 1925 and has been based at University Street in Belfast since 1933. The Society is a professional regulatory body for the pharmacy profession across Northern Ireland and also acts as a professional representative or leadership body for the profession. We're governed by a publicly appointed council of 14 members, 7 of which are lay persons and 7 of which are pharmacists registered with the Society. In terms of our regulatory functions, these objectives have been met by registering and regulating pharmacists, trainee pharmacists and pharmacy premises across NI. And on our register we currently have roughly 3,000 pharmacists, 200 foundation or trainee pharmacists and around 540 pharmacy premises. The Society's leadership functions or responsibilities are carried out by the Pharmacy Forum, is managed by a board exclusively comprised of pharmacists registered with the Society. As you may have already inferred by the date of our establishment, we are in our centenary year, and it is a matter of great pride for myself as a registrant, as a pharmacist, to be the Chief Executive of the Society as it moves into its second centenary. We're here today to discuss proposed legislative amendments related to initial education and training of pharmacists. And as I mentioned, I'm grateful for the committee's time in considering this draft SR. The Society and the Council are rule-making authorities, and we can make regulations with approval of the Minister of Health. And that's why we're here today. The Minister has given approval or consent to make these regulations. Hopefully members did have an opportunity to consider the SL1, which details the objectives of the proposed statutory rule. It may be helpful to give a very brief overview of what we're hoping to achieve. The process for becoming a registered pharmacist in Northern Ireland is set out in statute, namely the Pharmacy NI Order of 1976 and the Subordinate Pharmaceutical Society of Northern Ireland General Regulations Northern Ireland 1994. That's these 1994 regulations we're hoping to amend. In general, to become a pharmacist, a person must complete an undergraduate master's degree in pharmacy in an approved university, complete a pre-registration or foundation trainee year, again, which has been approved by our council, and complete an examination at the end of that training year. And after this, they can apply to join our register and register as a pharmacist. In recent years, our council has approved a new training pathway for pharmacists, which will ensure those pharmacists who join our register are able to join as independent prescribers, so they can prescribe medicines from the date of registration. This makes changes to the foundation year training and allows for different practice settings, such as across hospital, community and GP practice pharmacy settings. It also makes changes to the examination at the end of the training year. And the legislation we're hoping to make is required to support this new model and the new pathways of training. That's all based on statute. There are a number of other ancillary matters which support this and are detailed in the SL1. I can discuss if members wish, but if not, I'm happy for any questions. Thank you.
All sounds pretty straightforward. Danny?
Thank you, Canis. You mentioned that the consultation responses were broadly supportive, but some minor changes made during engagements with the department. Could you outline what specific concerns that came out of the consultation and how they were addressed?
There were a number of concerns. Probably the biggest one was in relation to educational supervisors. So previously, in the previous regime as such, or training year, a pharmacist would have had a single educational supervisor, sort of one pharmacist, one trainee rule, essentially. that has been changed to allow educational supervisors to supervise more than one pharmacist. I think the concern was this would dilute the time or the oversight or the mentorship of as opposed to one singer, one songwriter, Danny. But there are changes to really support the change, and that they're practice supervisors as well. There's layers of supervision in the legislation and the training year to really counteract the previous regime.
Okay. Has there, following on from that, has there been an impact assessment carried out to evaluate how this may affect pharmacist workload, particularly considering existing workforce pressures and the Minister's shift left agenda?
Not by the Pharmaceutical Society. We approve the trainer, the training provider. But no, as such, we have not carried out an impact assessment on what that workforce pressure might be. I'm not sure that would be for the Pharmaceutical Society.
Are there any additional resources or any additional support for the pharmacists who are taking on more than one training?
We're the health service, or who might be the employer, and that's not a matter for the society.
No problem.
Okay. There's nobody else looking to ask questions, so members, can I ask if you're content with the merits of the policy and the statutory rule be made? Content?
Yep.
Canis, thank you very much.
Very much. Thank you.
Okay, moving on then, item number 7, oral evidence from the Department on the Adult Protection Bill. Can I refer members to papers at tab 7? So, with the clerk's memo, page 72, the bill, as expected to be introduced, is at page 74, and we've all been provided with paper copies. Explanatory memorandum at page 106, and delegated powers memorandum at page 7 of the tabled papers. So, I'll have to read that bit slower in future. So, can I welcome Mark McGuckin, Director of Disability and Older People, and Kerry Loveland Morrison, Head of Adult Safeguarding Unit. So, you are both very welcome, and I'm going to throw open to yourselves once you get a wee drink of water to provide some brief opening remarks.
Thank you, Chair, and good afternoon. Thank you for the opportunity to provide the Committee with an update on the draft Adult Protection Bill. As you've noted, I'm joined by Kerry Loveland Morrison, and Kerry's headed up the team who have been leading on drafting the bill. Our current position is that the draft bill and accompanying explanatory and financial memorandum were approved at the Executive meeting on the 5th of June and were formally introduced to the Assembly on the 17th of June. Prior to this, the Attorney-General had confirmed that the bill as drafted is within the legislative competence of the Assembly, and the business case has been approved by DOF. The business case was approved on the condition that the bill was not enacted until such times as the necessary funds are available. This means that the draft bill will be introduced, but implementation will be delayed until such times as the budget becomes available. You will see in the paper that implementation of the bill will cost approximately £12 million in the first year and £120.8 million over the first 10 years of implementation. This is all new funding and largely attributed to additional staffing costs associated with implementing the new powers. Other costs relate to the Adult Protection Board, training, court fees for new offences, etc. I suppose it's worth noting, Chair, that it's unlikely that all the new staff will be recruited in 1 year. Therefore, while the business case identifies costs per annum, it is likely that the actual spend will be more graduated as a result of incremental recruitment. A business case dedicated to the implementation of the draft bill will be developed in due course and will fully consider the affordability of implementation at that time. As you're aware from our briefing last year, the draft bill will introduce additional duties and powers to strengthen and improve the adult protection process and help bring Northern Ireland in line with other parts of the UK where such legislation already exists. The Republic of Ireland does not currently have specific legislation in relation to adult safeguarding. The programme for government for 2025 includes a commitment to publish a national policy on adult safeguarding for health and social care sector, and it's expected that the finalised draft policy will be before the government in the coming months and that the preparation of legislation will commence thereafter in the Republic. Our bill team, headed by Kerry, regularly engages with other four nations on safeguarding issues and legislation. The draft bill itself is based on 7 key principles: prevention, autonomy, empowerment, dignity, proportionality, partnership and accountability, which have been incorporated within the draft bill and should be adhered to by everyone involved in adult safeguarding and adult protection. The draft bill will introduce a duty to report and a duty to cooperate, where a number of organisations such as trusts, police, RQIA, probation board, housing executive, GPs and independent providers will have a statutory duty to report to the relevant trust any cases where they believe there is a reasonable cause to suspect that an adult meets the criteria of an adult at risk. Subsequently, the trust will have a statutory duty to make inquiries in all these cases that are reported that are brought to their attention. The draft bill will also introduce the power to access records, which includes financial records, the power of entry and associated additional powers such as assessment orders, removal orders and banning orders. These powers will be used by specifically trained adult protection social workers, and a number of conditions will need to be met before these powers can be used. For example, magistrate's approval will be required in all instances, and there must be a reasonable attempt to seek the consent of the adult involved. The draft bill will also introduce a statutory provision of independent advocates who can assist adults at risk to be involved and influence decisions taken about their care. The draft bill will also empower the Department to establish an adult protection board for Northern Ireland and place that on a statutory footing. That board will have a number of core functions, which will include responsibility for carrying out and managing serious case reviews. Finally, the draft bill will also see the introduction of new offences relating to ill treatment and willful neglect, namely the care worker offence and the care provider offence, which are intended to cover instances of harm by care workers and care providers, which may not be captured by existing offences in Northern Ireland. These offences are similar to those already in place in England and Wales under the 2014 Care Act. As we noted previously, Chair, there is one outstanding issue related to whether the Northern Ireland Prison Service should be included under Duty 4, which is a duty to report. No final agreement has been reached with the Prison Service at this stage, and as drafted, the bill does not therefore include Prison Service within Clause 4. We remain of the view that prisons should be included in this duty. Engagement continues with Prison Service colleagues on this issue, and there's a potential that the clause will be amended at a later stage throughout the assembly stages if we get agreement with prisons to be included there. And in closing, Chair, I would like to place on record the Department's sincere thanks to the Office of Legislative Counsel and the Attorney General's Office for their assistance in drafting the bill. And if I could also add our thanks to the committee clerk and staff for their assistance in terms of walking us through the process of what the bill will entail. Happy to take any questions today, Chair, from members, and if we can't answer today, we're, as always, happy to come back in writing.
Just the point on the prison service, so the department want the prison service to be included, but there's resistance from the prison service, is that right?
I wouldn't say resistance, Chair. We engaged probably a bit late with prison service, although we have been engaging for over a year with them now, and the Department of Justice were represented on the transformation board. I think prison's position would be that they're still looking more clarity on how this would impact with people within the prison estate, particularly some of the specific powers, but we're having those ongoing conversations, and actually the Minister Long in her response to our minister's letter going out to executive colleagues was very supportive of the bill and noted that further engagement was needed with prisons, specifically on Clause 4.
Yeah, and would it be the department's view not to make an amendment to include them if prison service weren't fully happy with it, or would you put an amendment regardless of reaching agreement?
We would like to get an agreement on that position, but it is our position that we believe prisons should be included in Clause 4, Chair.
Fair enough. And then just in terms of the point about the bill, but there's no funding and the implementation, so bill's going to be legislation, but in terms of implementation until funding is found, is that what I took from what you were saying?
It is, Chair, and I suppose the position was taken by the department. We could have went two ways. We could have waited until the finance was available and then start the passage of the bill, or we can bring the bill to the statute book and then look for the funding. We can also look to implement on a staged approach, although we don't believe a lot of the powers within the bill could be brought in incrementally, because we wouldn't want a case to be taken to a certain stage where an additional power would be required, and if that power wasn't on the statute book, it would mean the case would fall. There are things potentially around the likes of the bringing forward the Adult Protection Board. We could maybe think of doing something like that as the first step, because that is quite low cost. And a lot of the costs, as we've noted, is in terms of recruitment of additional social workers and other staff around that. So to answer your question directly, Chair, yes, it is the position that we will bring the bill to the statute book if we get it through the Assembly, and then we will seek to implement at a later stage. And trusts have been clear as well. They will need some time, even when it does, if we get it through to royal assent. Trusts will then need a period of time actually to get the training and to get a lot of the other processes in place before we would actually go to implement. So it's not that we, even if we had the money, we could bring this forward on day one after assent. So there will be a lead-in time in terms of commencement of some of the powers within the bill.
I mean, obviously, as this bill passes or goes along its different stages, I mean, you would potentially see that implementation plan and the details of it, and even by the end of it, the Minister may have found the money to implement it.
Certainly it'll be a parallel approach. We're still developing statutory guidance as we go through the process as well, Chair. So certainly the implementation, we can look at an implementation plan in parallel with bringing the bill through the Assembly.
Okay, thank you. Nuala?
Thank you, Chair. Thanks, Mark, for that presentation. I think this is great to finally get this up and through the Assembly to really start the first stages. I think the families of the vulnerable adults in Muckamore and from the Dunmary Care Home will be particularly interested and delighted to actually, see this now get off the ground. So no doubt we will continue to hear more from them, and we'll have more specific questions through the committee stage of the bill. So a few questions that I just have now. Regarding the Chair asked about the financial commitments and being able to implement it. When I was reading some of the briefing paper, like for example, the statutory duty to report, I don't understand why that couldn't be implemented, at cost neutral. I mean, including a statutory duty to report, I mean, forgive me for my ignorance, how that would cost or need a financial tag to it. And is that something that you think that possibly will be able to be implemented?
I suppose now in terms of a statutory duty to report, the Trust then have a statutory duty to investigate, and a lot of the costs will be around ensuring that we have the necessary social work workforce to enable that investigation to be taken forward. So that's what I was trying to say. If we implement certain powers within the bill and not all the powers, you get to a certain stage and then you're not able to do anything to progress that right through. So you're right, introducing a statutory duty to report to the trusts probably doesn't cost anything, but actually implementing and investigating that then is where the cost lies, because as I say, you need the social workers, you need the other staff in place to actually carry through that investigation, and you would also need those other powers to make sure that you're able to take the investigation right through its course in terms of some of those other powers within the bill.
But my understanding, and maybe I'm wrong, is that these could potentially replace ineffective investigations into what needs reported, or is this to duplicate? So would you not be cutting out in other areas where they were previously should have investigated?
Well, I suppose at the minute it's all done through a policy rather than a statutory power. So this is to strengthen what is currently in place. But we've had a lot of engagement throughout this, and the Office of Social Services have been involved in the Transformation Board taking this forward. So their view is clear that we need additional social workers in place, Nuala, to be able to actually deliver this to the full extent of the bill. So I'm not sure that we would say it's ineffective powers at present, but it certainly will strengthen the powers that are there. But there are already significant vacancies within the social work cadre in Northern Ireland to take forward the investigation at present.
No, I understand that. I completely understand that. My worry just is that we will have this act, and because the funding situation is not able to implement many
parts of it. However, whenever we meet with families, whether it is around SAI procedures or internal investigations or RQIA investigations, there already are ones that do exist. So I think perhaps exploring it a bit further at committee stage is what will these be kind of strengthening or replacing rather than duplicating, so as we can get to the position where we can implement something.
I think specifically in terms of clause 4, where there would be a duty on those named organisations to report, and then for the statutory duty on the trust to take it forward. I think that's a huge step forward, Nuala, in terms of strengthening what is currently there. Certainly happy to come back as it goes through the assembly stage with more detail on that.
Yeah, I understand that's not needing to go into all the detail now. Another area that, again, you don't have to provide the detail, I'm just thinking with regards to getting more in depth, is when you use the words power of entry, financial records. I think it's really important to elaborate further on the benefits and why that's necessary for us coming through committee stage of the bill, because I can see it. But I can see it from the work that I'm doing with families, but others may not see so themselves. And the only other question that I did ask is regarding the regulations that could be made under the use of CCTV. Do you anticipate these regulations being drafted now or after the bill gains royal assent, or do you think there will be some sort of time delay? Because a lot of organisations and families, would ask questions around CCTV within care homes, and had it not been for CCTV at Muckamore, we wouldn't have been able to uncover quite the scale of abuse there. So my concern is just the time delay with regards to the regulations. So this will be the first bill that some of us new MLAs will have had through a committee. So when do we think that the regulations being drafted would happen? For that aspect in particular.
So there's a bit of a piece of work that needs to be done around CCTV generally. It wasn't included in our initial consultation on policy proposals. Yeah. So because of that, we would want to actually have a full public consultation on the content of the regulations. So we would have that piece of work to do first, and then we would bring the actual draft regulations forward afterwards.
But that would be after the bill has been
Yes, I think so. Although the consultation may happen earlier, we'd have to see where we got to in terms of timing. We also are planning a public consultation on the statutory guidance as well. So there's 2 pieces of work that need to be progressed there.
Okay, thank you. I think it is certainly important, that one, because when you ask people who are in positions of responsibility, would you put your loved one in a care home that didn't have CCTV? I haven't talked to anyone who's said yes. So it is an important aspect. But I do appreciate that it wasn't in it at the beginning, and I think it is positive to see that the department has actually moved to make ways to include it now.
And just on your wider point, Nuala, in terms of mandatory inclusion of CCTV, it was very clear that it wasn't possible. It was outside the competence of the legislative competence of the Assembly to bring that in because of Article 8. But I do very much take the point that without the CCTV evidence, we probably wouldn't have uncovered the extent of the abuse in Muckamore, and we're very alive to that. And actually, some of the members of the Transformation Board would have been, particularly PSNI colleagues, would have been behind mandatory CCTV, but we simply weren't able to introduce that within the bill. And to be fair, it would also, if we'd have included mandatory CCTV, it would have made it mandatory then in some individuals' own homes, particularly around some individuals who are supported through supporting people and supported living, because that is their own home. And if we were to include mandatory CCTV, it would include then in people's own private homes to make it mandatory. So we couldn't do it simply.
Okay, thank you very much. It's all the questions that I have for now, but thank you.
Just before I come to Linda, in terms of the question Noah asked, and you talked about clause 4, Mark, about the difference and the impact of the duty to report and then the duty to investigate. There's no time frame. So if I report an incident on a Monday, is there there's no time frame for when the other duty to investigate needs to kick in? Because obviously, if we're talking about reporting something that's maybe an adult in a vulnerable situation, you would expect that investigation and work to start immediately or very, very quickly, but I can't see anywhere in the bill where there is a time frame. So somebody could say, yeah, I'll investigate, but it might take me 2 weeks. Is that an omission? Or
Yeah, I think in terms of that kind of detail, that's where we would want our statutory guidance to be filling in the gap, to talk about what the process actually looks like. And I think that different cases might have a different timeline because you would reflect the urgency of the situation at hand. But I would expect our statutory guidance to cover that detail, Chair.
Okay, thank you. Linda?
Thank you. And a bit like Nuala, I don't know how much detail to go into today, but just, I suppose, on a couple of points. So clause 2, 3, Mark, just around the bill, the defining harm, so physical, psychological, neglect, financial, etc. But there isn't a provision for a review or update mechanism for the definition in response to emerging harm types. I'm just wondering, do you think it's flexible enough to sort of deal with those emerging harm types? So I'm thinking probably mainly digital and online and coercive control, that wouldn't come under the domestic abuse legislation.
That's a very fair point.
That is interesting.
Linda, to be fair.
I'm going to leave it with you, right? So you can take that away as a point.
Yes.
I'm happy enough for that because I'm not expecting you to have answers to everything that I'm going to raise today. Can you see in terms of the heading where it's adult protection rather than safeguarding? It's only a point of interest. I'm wondering why.
So safeguarding would be seen as a wider umbrella that would include other elements such as prevention and so forth as well. The bill is focusing specifically on protecting people, investigating where you think harm might be happening,
so it doesn't have
and
the
then dealing with
preventative
it.
stuff in
Yes.
it. Yeah, okay, no, that's fair enough. And then just clauses 17 to 19, the powers of entry and application for warrants. So safeguards are mentioned, such as the need for consent unless capacity or undue pressure, but the bill doesn't reference any evidence base, or examples of intended use. So just our detail on how stakeholder input shaped the powers. So I'm just wondering, do we have, is there evidence to?
So
what's the evidence base?
If you were moving away from the consent issue because you felt someone didn't have capacity or because you felt there was undue pressure, the trust would need to make that case to a magistrate for them to approve the power to be used.
A lot of this will be down, Linda, to the professional judgment of the social worker involved in the case as well. So, and there will be significant training brought in there for the social workers coming in, and we expect it to be a particularly high grade of social worker dealing with these cases. It won't be just social workers, and I'm not being disrespectful here, straight out of university days. They will be experienced senior social workers taking these cases through.
It's probably just something for us as a committee to get a sense of from the stakeholders, I suppose, as much as anything, what they feel about that. Then the general duties to cooperate in clause 4 and consult in clause 22. So direct participation by families, carers and service users in the governance of the Adult Protection Board or guidance development isn't mandated in the bill. So I'm just wondering how will the department ensure that all of those people are included in terms of the process, not just as a consultation but actually.
Well, we have included a clause that the trusts must keep families and other interested people involved throughout the process, that they must have due regard to their opinions. And that really came from our engagement with stakeholders and families themselves. They let us know how important it was that we have something in the bill to guide that, because they feel that's something that doesn't always happen as much as it should now. So that's really where that part of the bill comes from, through engagement with them. And we hope that that will help to reassure families of the importance of their contribution to the process. We do see it, and the trusts do see it as well. And I will say the trusts were fully on board with that being brought into the bill.
I suppose my concern around that is just that the duties to report and cooperate, and being on the policing board, I'm well aware of where there have been duties on PSNI and Trust to cooperate before, and where that cooperation is fallen out. I suppose I'm just a wee bit concerned about how we make sure that is really is borne out as it's intended in terms of accountability. So I suppose again that's something we'll probably get into more throughout the I mean the other questions that I have already been asked by the chair and answered. So no, look, thank you. I mean, I'm sure you'll be sick looking at us before this is out, but it is really an important piece of work, and it's good to have legislation in front of the committee to scrutinise. So
absolutely, I think we're all looking forward to it. Alan.
Thanks, Chair. Just on the CCTV system part of the bill, we've seen how important CCTV has been in the past. Now I realise that you've said you're still sort of working around, the fine tuning of it and what regulations will come in, but just a couple of things sort of spring out at me. You're saying that the regulations may make provision but they need to inform and seek the consent of those residing or accommodated in or using the services provided in. Say it's a residential situation where maybe there's a turnover of residents, or there might be people there for maybe only a short term, like a respite situation. How would you accommodate if one of those people decided that they wanted to object, but there might be another 30 or 40 people on the premises who are quite happy to have the CCTV? So I'm wondering would you be thinking about a threshold, like if 10% of the people or whatever? The other thing is you're saying about the use and maintenance of a CCTV system. You might get somebody trying to be clever and saying, oh, well, our CCTVs, it's out of order at the moment and we're getting it fixed. Would you foresee some sort of compulsion on, a timeline that you have to get it fixed within 72 hours or something like that, so people can't hide behind that excuse it's broke, but we're bringing down an engineer about it. And the other thing was I don't know how long the records or what the regulations were around Muckamore, but I suspect that the footage there was saved for quite some time. So would there be something in the regulations that would inform operators how long they would have to retain the footage?
That is the kind of detail we would expect to be looking at in the regulations. Being totally honest, we haven't really gotten into that detail yet. We haven't started really developing the regulations at this time, but that is the kind of detail that we would expect to see, and I would certainly expect to see it looking into the regulations would go into details such as maintaining the CCTV in a reasonable time frame. Having it operational within a reasonable time frame, who can operate it, all that kind of detail.
Yeah,
and they're the sort of conversations, Alan, sorry to interrupt, they're the sort of conversations we've had at the Transformation Board as well when we're discussing what the regulations around CCTV should be, particularly from stakeholders like PSNI, who are saying these are the sort of things we need to make sure that we have regulations around so that people can't hide behind, the system's been down for 3 weeks or something like that. So they were particularly insistent that that's the sort of regulations we should have around CCTV.
Excuse my ignorance about how these things actually work out, but in terms of the bill does go through and passes, and then you're talking about, you'll start to brainstorm about regulations and the fine tuning of it. How do you work that into the bill then? Is there provision within the bill for you to add those addendums?
It comes through as secondary legislation, and we have put it down that it will be draft affirmative legislation, so it would come to the Assembly, be laid before the Assembly as a draft, and then it would have to be approved by the House and by yourselves as well.
Every day's a school day, thank you.
Thank you, Alan. Thank you. Danny?
Thank you, Chair. This is great to see. This is a new thing for me, and it's great to have legislation actually coming to it. So fantastic. And I know we're going to become very, very familiar with this. So, a couple of questions. We realise that obviously the funding isn't there yet. Is there a prioritised plan for a phased approach if only certain amounts of funding are available?
At this stage, there's not, Danny, and I suppose we probably want to take advice from the committee as it goes through the passage of the bill. Once we get into the detail of what the powers will actually be, we would like to have those conversations as part of the passage of the bill to see if there's a prioritisation that you believe we should take this forward in. As I, from my perspective, it would be difficult to implement the powers on an incremental basis, because I don't want, as I've said before, you don't want to get a certain point in a case and then not have the necessary powers to take it right through. I said that it might well be that we could bring in the Adult Protection Board as an interim step, because again, they can still look at powers around serious case reviews and other issues there. So that would probably be one of maybe the first steps we could look at, would be the board, because it would be relatively inexpensive to bring that in. There's an awful lot of other costs associated with training and things as well. So and obviously the majority of the cost is around recruitment of additional social workers. So again, we're looking, we're probably at this stage, I think this year, we're at the highest ever in terms of our intake of social workers. We have 340 commission places for September, 25 going through University of Ulster, and then some more through the Open University as well. So we're already starting, a lot of that was from additional places were through transformation funds, which are largely looking at social work provision within MDTs, but it is already starting to get some of those additional social workers in place. So by the time the bill comes through, we should be in a position where we have more social workers on the ground to maybe then have those conversations around what the prioritisation might be.
Thank you for that. It leads me on to my next question, because obviously one of the things we've heard a lot about here is social work teams that have excess numbers of vacancies and heavy workloads. Good to hear. Obviously, well, we knew that the commissioned places obviously are coming in, and that's the graduate social workers who are coming straight into it. So these social workers will be experienced.
Well,
they'll be ones who will be going for the training. Has there been an assessment of the workforce issues, of the workforce availability, to be able to make up those numbers?
In terms of vacancies, the latest figures that I have, that we have 255 vacancies across trusts at the minute. We expect to bring in 240 new social workers in July and September, and I think the committee are aware previously that we are now using like a fast track recruitment process for social workers. So all the social workers coming out will be within posts within the trusts. Those 240 within posts within the trust within July and September. So when we put that in, and then we have another 340 people starting the course in September, which is, as I say, is the baseline is around 285 health commission places each year, with 340 getting in this year, with an additional 15 through University of Ulster, and then some more around another 5 around Band 7 recruitment and retention coordinators as well going in this year. So I think the department is making good strides in terms of trying to bolster that workforce. So by the time this goes through, the position in terms of vacancies should be different than it is at the minute. I would imagine by the time it goes through as well, we will have had another cohort of staff graduating through university. So again, that'll be more social workers coming into the post in September 26.
You'll also have a cohort that will have left on the other end.
Yes, so you have that natural churn as well, and invariably the ones who are leaving probably are your more experienced social workers, which is the point probably I think, Danny, I'm trying to answer for you. But what we didn't want to do was simply bring in something and exacerbate the current difficulties in terms of staffing in the social work. So by looking for that additional funding, that will allow us to have that amount of churn as well in the system, to allow to continue to bring more and more new social workers in, and allow those more experienced social workers to take on these sort of roles. So that has all been factored into the costings in the bill.
Okay. This is very interesting, and looking forward to getting into the teeth of it here. So thank you.
I just have one last question then, because we talked, or I asked about the prison service, and you said a potential amendment. Is there anything in your view that you may bring forward as a potential amendment that you have in your heads?
That's the only one at this stage, Chair, that we would potentially bring forward.
Fair enough. Thanks very much. We'll be sick beside of each other probably before this process is over.
Thank you, Chair.
Thank you. Okay, members, moving on then, item number 8, oral evidence from the Department on the LCM for Mental Health Bill. So can I refer everybody to papers at tab 8? LCM is at page 151. The Mental Health Bill itself is at page 153, and there's amended text at page 32 of the table papers. Just while we're taking the break, the clerk has very helpfully sent an email to members in relation to legislation and assistance that he can provide, or advice or training if anybody wants to avail of it. Okay, so can we welcome departmental officials? We have Heather Stevens, Director of Mental Health, Debbie Sharp, Head of Mental Health Strategy Delivery Unit, and Brian Cassidy from the Mental Health Strategy Delivery Unit as well. So you're all very welcome. And going to hand over to yourselves just for some opening remarks, and then we'll take questions if there are any.
Thank you very much, Chair and members, for the opportunity to brief you today on the UK Government's Mental Health Bill and its proposed modification of the Human Rights Act. As you've said, my colleagues are here with me today who work with me closely on all matters legislative in terms of this. By way of background, the UK Government's Mental Health Bill, which was introduced back in 6th of November 2024 to Parliament, aims to modernise the Mental Health Act 1983 for England and Wales. That legislation is the equivalent of the Mental Health Northern Ireland Order 1986. And it aims to do that by enhancing patient autonomy, patient rights, and also providing greater transparency. And it's doing a number of things, for example, tightening up detention criteria, providing for more frequent reviews, and also removing prisons and police stations as places of safety. But just to reiterate, this is an England and Wales piece of legislation. In the main, those provisions will not apply to Northern Ireland. So the amendment under consideration was tabled very recently on the 3rd of June this year, and it takes forward a commitment made in the Lords to address issues in relation to the unequal application of the Human Rights Act for some mental health patients. It addresses a gap in that Act's protection for mental health patients following a High Court ruling in a 2024 case called Samet v Next Steps Mental Health Care Limited. And the purpose of the amendment is to ensure that providers delivering specific mental health services, when arranged or funded by public health bodies, are subject to Human Rights Act obligations. So the amendment seeks to modify, it's described as a non-textual modification of the Human Rights Act, which is a reserved matter, and so subject to the Assembly's approval with respect to Northern Ireland, it would apply UK-wide. It designates private providers as exercising a public function when they are providing aftercare services once a patient is no longer detained under mental health legislation, or voluntary inpatient treatment or assessment for mental health disorders. So under this amendment, private providers will be taken to be exercising functions of a public nature for the purposes of Section 63B of the Human Rights Act when they're carrying out those functions and when those functions have been paid for by a public body. I should say that private providers are already taken to be exercising a function of a public nature for the purposes of the Human Rights Act. If they're caring for patients detained under mental health legislation or providing care for mental health patients, for example, in a care home. But it's important to make the point that currently we have no private providers in Northern Ireland providing this mental health inpatient treatment to patients in Northern Ireland. But this is about future-proofing the position so that if that should change at some point in the future in Northern Ireland, then the same Human Rights Act protections which are available to mental health patients in the same situation in the other jurisdictions is also available here. And we consider that the amendment supports the Bamford principles, enhancing patient rights, dignity. It's about holding providers to account under the Human Rights Act. And I think critically it ensures that uniformity of application, preventing regional disparities. And we feel there may be some public criticism if the Assembly were not to extend such protection to citizens in Northern Ireland. I think it's also important to highlight that the Act and this amendment does not do anything else to alter Northern Ireland's mental health framework. That will stay as it is. So why can Northern Ireland not make this change itself? Well, as I've already mentioned, the proposed amendment modifies the Human Rights Act, and so that in itself, as part of the devolution settlement, is considered a reserved matter, and so it's outside the Assembly's legislative competence. But because it affects the devolved issues of health and social care, that's why a legislative consent motion is required. And so the Assembly has power to decide whether this amendment extends to Northern Ireland or not. That is within your power, but it doesn't have the power to make that modification to the Human Rights Act itself. So if it's not done on this occasion through this amendment to this bill, there's no other vehicle in order to do that. So in light of all that, on the 10th of June this year, the First Minister and Deputy First Minister agreed that a legislative consent memorandum should be laid in the Assembly to facilitate this extension of the Human Rights Act. And the next parliamentary opportunity in Westminster to move the amendment will be at report stage in the Commons, which, subject to parliamentary timetabling, is scheduled to be at some stage in the autumn of this year. And we, the Department of Health and Social Care, have been very mindful of the need to allow time for the Assembly to consider and make a decision in relation to the application of this amendment, and for that decision to have been made before the amendment is formally moved. In terms of consultation, our department has collaborated with DHSC in terms of its scope to ensure that the amendment reflects Northern Ireland's position and to absolutely make sure that it does not change our legal and mental health framework. And I think it's important to note that no other Northern Ireland concerns have been raised as part of the debate. In terms of consultation, this is largely, as you would expect, have been undertaken by DHSC. It was raised originally by the government by peers with broad support, but officials, we have reached out to the Northern Ireland Human Rights Commission for their views and await their response. But just to recall that the aim of the legislation is about protecting and enhancing human rights rather than restricting them. In terms of financial human rights and equality implications, DHSC has confirmed that the bill is compatible with the European Convention on Human Rights, and the UK Government's working assumption is that it will not require additional funding or be considered a new burden for public bodies. In fact, there's an expectation that the impact of this amendment on private providers in the UK providing services on behalf of a public authority will be minimal, as guidance already sets out the expectation that they are compliant with human rights. So there's already that expectation on providers in the UK to act in line with the Human Rights Act. The bill's explanatory notes give an indication of the financial implications in England and Wales should it become law, and there are no anticipated financial requirements locally associated with the proposed new provisions. But of course, at some future point, should we have private providers in this space, potential compliance and legal liability costs for health and social care trusts may arise, although specific financial impacts cannot be quantified at this stage. The amendment promotes equality by ensuring consistent human rights protections for all mental health patients, including those in private care settings. And in terms of regulatory impact, the DHSC's impact assessment has identified no significant regulatory impact. The amendment just clarifies the Human Rights Act application with no additional burdens on private providers beyond that compliance with the Human Rights Act. The amendment also only applies to registered providers, and so therefore they're already subject to regulation. In Northern Ireland's case, this would be through the RQIA. And to be registered with RQIA, there's already an element of compliance required, although perhaps not as explicitly as will be provided on the face of the bill. There's no specific impact in Northern Ireland anticipated on employment, on charities, on social economy, enterprises in the voluntary sector, and we would anticipate that monitoring will occur through existing mental health service frameworks with feedback from the trusts and via service users. In terms of rural impact, again, no specific rural impact has been identified or expected. We're not aware of any data on whether private provision would be more likely to take place in urban or rural areas. In terms of data protection, again, any obligations around data sharing and protection would be set out as part of the arrangement between the public authority and the private provider, and that's not within scope of this legislation. So I think that's all I want to say, Chair. Perhaps just in conclusion to say, although we are briefing the committee today on this very specific amendment, we are monitoring the progress of the mental health bill through its parliamentary stages to assess whether there is anything else within the scope of that legislation that we might want to consider at a future point for Northern Ireland, and that would be within the devolved competence of the Assembly and would be included in a mental health bill. Thank you.
Thank you very much. That was very thorough. So, I mean, essentially, with regard to this, that we have no mental health private mental health providers that would be doing this. So it's as you say, future-proofing it. So as such time we did have. Can I ask, just in terms of private mental health providers? I mean, is that like a counsellor? What, I mean, can you give me an example of?
No, a council would be defined as a public body, very broadly. So it would be literally like a private sector provider, in the same way that you get independent care providers. But we don't have independent mental health providers who receive mental health patients as inpatients. Okay.
Very good. I mean, that's fair enough. That clears that up. I mean, my other issue is around the timing of it. Obviously, I mean, the committee has a process, the Assembly has a process. So, I mean, and my understanding is that the last stage of amending process at Westminster is during the summer. So, I mean, given that, can you confirm the date of the debate in September? There's still time for the Assembly to approve or not approve the LCM.
So the Assembly would need to approve the LCM before report stage. We're still waiting for confirmation of when that report stage will happen, but it is very likely to be in the autumn. It won't be over the summer. Okay, fair enough.
We were very keen to push that back to DHSC colleagues to make sure that the due process could be followed within the time limits of the Northern Ireland Assembly.
Because this amendment has arisen very, very late in terms of your term, and you already have a busy programme of work, so it's not an unreasonable ask.
And in terms of the coming to us late, I mean, that was because the amendment was made in Westminster late. It's nothing to do with the department.
It was tabled on the 3rd of June, and we had a submission to Minister seeking an urgent decision on the 4th of June, pretty much.
Well, it was pretty quick turnaround then. Okay, thank you. Danny?
Thank you, Chair. Just to confirm, I think Philip's already sort of asked, so the services are inpatient mental health services within a building, within an organisation that's delivering those services in an inpatient setting?
Yes.
So it's not about a counsellor having a counselling operation, private counselling operation, that would not be included?
No.
No private doctors that are offering mental health services, that wouldn't be included?
No.
So just that inpatient?
It's inpatient and also aftercare services for after someone has been detained. Mm-hmm. But it's very specific, and it's because of this particular case. And in England and Wales, they identified that it would cover perhaps 1% of those. So it's very, very niche, and it's because of this particular case which flagged up this particular gap. That's not to say that at some future point other gaps may be identified, in which case an amendment, a further amendment would need to be made. This is specific to the situation of that case.
A few other quick questions just around this. Just with that, I think you've already alluded to this, I think. How will the department ensure effective monitoring and compliance then?
Well, at the moment, there is no compliance because we don't have providers operating in that space. But if there are, it will be done through the SPPG and Health and Social Care Trust standard process, and obviously service users input to that process, and so that's how it will be done, in the same way that monitoring is done of the trust's services. You know, this will be something that would be contracted out by a trust, and so they will report on that in the same way that they report on any other service which they contract out.
So patients and families will have the ability to give feedback and be able to feed into that. Yeah,
we would very much envisage that.
No problem. Thank you very much.
Okay, Heather, Debbie, Brian, thank you very much. That's been useful. Thank you.
Thank you.
Okay, members, can I ask if we're content with the LCM as laid? Okay, so clerk will prepare a draft report outlining our consideration of the LCM for next week's meeting. Just going to move on then to item number 9, draft committee report on the LCM for the Rare Cancers Bill. Can I refer members to the committee's draft report on the LCM at page 35 table papers? Everybody happy to agree the report as drafted? Content? Okay, thank you. So also, can I ask if you're content that the report be published along with the appendices? Okay, thank you. These are very enthusiastic about agreeing all these matters. Item number 10, written briefing from the Department on Maternity Services. Can I refer members to the written briefing at page 46 of the table papers and ask if there are any comments? Okay, none.
Sorry, hold on, Chair.
No. Okay, moving on then to item number 11. Written briefing from the Department on the Mental Health Strategy. Can I refer members to the written briefing at page 161 and just remind members that the Mental Health Champion is scheduled to brief the committee on the 16th of October. Can I ask if members have any comments? None? Okay, so correspondence. Can I refer members to correspondence? So refer you to ministerial correspondence at page 169. Sorry, I'm going to start and say that we received our table papers very late today, and there are a number of items of correspondence and it referring to the kind of ongoing issues with the cardiac unit. I'm going to suggest, just to allow members the appropriate time to consider those, that we actually don't deal with those today, that we get time to go through them in detail and we bring them back next week, if everybody's happy with that as a starting point. Okay, then just can I refer members to page 169, Department's Policy Guidance on Change and Withdrawal of Services, Guidance on Roles and Responsibilities, just to ask if anybody has any commentary on that. None? Okay, can I refer members to a response from the Department at page 184 concerning the oral briefing by the Royal College of Paediatrics and Child Health on paediatric waiting lists? The only comment I would make is that they didn't really provide any of the information that we kind of asked for. So, I mean, I don't know if we want to go back to them, if there's any point in going back to them. I mean, we kind of asked how much of the 215 million would be set aside for reducing paediatric waiting lists, and they really haven't answered the question. Linda?
This goes back to the point I made earlier. Children's services at every level, within every part of the department and trust, just seems to not be a priority in any way, shape or form. There is an event this incoming week, I think, if I'm right in the dates, the Royal College of Paediatric Surgeons are at, so maybe it might be worth asking them at that, or have they been made aware?
Okay.
But I mean, it's up to you, I think.
Dan's looking on.
Yeah, can I can I just say, I completely agree that I actually think that's quite a disgraceful response from the department. It actually refers to the waiting list reduction reimbursement scheme as some magic bullet that's going to help with waiting lists for children. You can't access this scheme if you don't have a diagnosis and a need. There are 25,000 plus children in the Southeastern and Belfast Trust alone waiting to see a paediatrician for whatever reason. I am flabbergasted by the level that actually goes to. And I do think we should, you know, I mean, I don't know which part of the department wrote that response, is the honest truth. But it is really, really poor. Maybe the paediatricians that are here next week can help us with it. But I think we should go back and say how disappointing that actually is.
Yeah, I mean, I think we should go back probably and say, given the figures that you have mentioned, Dan, that we're all aware of, just ask for a plan and how much again of the budget is going to be attributed to dealing with the waiting list, and then we can, at least they'll know next week, whoever's coming, that they're going to be asked that question.
Yeah.
Everybody content with that?
Yeah.
Okay. The other one thing then I wanted to raise, just table papers 12.1 was the letter from the department or the minister in relation to the community pharmacy issue. So all of us will remember the briefing that we had from the department, community pharmacy NI, and then the department just a number of weeks ago created a bit of headlines. Just community pharmacy were making their arguments about funding models. There was quite a bit of discussion in both presentations about comparisons with Scotland, and I mean the figure at that briefing that we were told, I mean the committee was advised that per head funding in the north 23-24 was 22% higher than the funding in Scotland, when we actually now know as a result of this error and the correction that it isn't 22% higher than Scotland. Scotland is actually 9% higher than the north, so that's quite a considerable transference of funding, and it's also quite a considerable error, I think, to have been made given the focus that we were putting on that issue during that presentation. So I mean the department have said, I mean they didn't apologise for misquoting, I'm trying to use my words carefully here, you know, we were misinformed essentially, and you know a lot of the discussion was based on that misinformation. So I mean I think they should certainly be apologising for that error. They said they're going to correct it. I mean my ask would be, just given that they were saying that community pharmacy here was funded properly based on misleading figures, that they should be engaging immediately with community pharmacy in regard to those contract conversations, and that you know we potentially consider re-inviting the department anyway back to the committee to have another session with them based on the fact that the figures were misleading and that we now have updated figures that show a completely different scenario. Danny?
Thank you, Chair. I absolutely agree with that. I was astounded on the difference between those two figures. It is very, very significant given the conversation that we were having with them. I see later on in the letter they've said now that the opening level of Northern Ireland funding 24-25 is 76.55 per head of the population, virtually level with the funding in Scotland. I think we need an explanation of that as well. So certainly I would like to see the department come back and explain first the mistake that they've given us, second how those figures equate. I would also suggest that we send this response to CPNI just for their comments on that as well, if that would be possible.
Absolutely. Yeah. Everybody happy? Okay, and then can I ask then if members, with the proviso of the issues and table papers with regard to the cardiac unit that we bring back next week, that if everybody's content with everything else that's in the correspondence.
Sorry, Chair, can I just say declare an interest as the Chair of the All Party Group in Community Pharmacy there as well.
Okay. Okay.
Other than that, yes.
Fair enough. Right, moving on. Item number 13, forward work programme. Can I refer members to the draft forward work programme, page 193? So, committee will visit the Ulster Hospital next week, Thursday morning. Any member who hasn't yet confirmed their availability to attend should do so immediately. Committee has asked that the visit be as informal as possible and not disrupt any of the work of the hospital, but it is an opportunity for us to see the IT system in operation. I mean, we've talked about it a lot and asked questions about it a lot, so it would be good to see. The Encompass Regional Programme will provide a brief overview and take questions, and then the South Eastern Trust will provide a local presentation. Okay, so everything else content in the forward work programme? Yeah. Any other business? None? Okay, so our next committee meeting is next Thursday, 26th of June, room 29, 2 p.m. Thank you.
Committee Room 29, Sound. Committee Room 29, Sound.